Now let's study acute respiratory distress syndrome. Let's see the pathophysiology. As we can see here, this is the alveoli and we have the capillary surrounding the alveoli. Due to any injury or alveolar insult, there will be release of inflammatory cytokines from the macrophages, and these inflammatory cytokines reach the surrounding capillary and call for the neutrophils, and these neutrophils, there will be activation of the neutrophil, and these neutrophils will release the reactive oxygen species and the proteases, and this increases the vascular permeability. Hence there will be leakage of the fluid from the alveolar capillary to the alveoli. Hence leakage of protein fluid into the alveoli leads to formation of intraalveolar hyaline membranes. That is, due to leakage of the fluid, there will be fluid buildup within this alveoli, and there will be formation of hyaline membranes. And here we can see the non-cardiogenic pulmonary edema, because in pulmonary edema, when there is pressure, increase in pressure due to left heart failure, there will be back pressure to the lungs that causes pulmonary edema, that increases the fluid in the interstitium and that leads to pulmonary edema. But in acute respiratory distress syndrome, here we have the non-cardiogenic pulmonary edema. That is, due to any insult, there will be release of cytokines, and this increases the vascular permeability, and this increases the leakage of fluid to the alveoli. Hence there will be formation of intraalveolar hyaline membrane. And due to loss of these pneumocytes, because type 1 and type 2 pneumocytes are necessary for decreasing the surface tension, especially type 2 pneumocytes decreases the surface tension by producing surfactant. When these pneumocytes are destroyed, there will be collapse of the alveoli. If this is the alveoli, normal alveoli, there will be collapsing of the alveoli due to decreased surfactant. This is the pathophysiology of the ARDS. As we discussed, there will be alveolar insult that leads to release of pro-inflammatory cytokines, neutrophil recruitment and activation, and release of toxic mediators like RAS and proteases. And capillary endothelial damage leads to increased vascular permeability and protein-rich fluid within the alveoli. This leads to formation of intraalveolar hyaline membrane. Here there will be non-cardiogenic pulmonary edema. In ARDS, we will have the normal PCWP, that is pulmonary capillary wedge pressure, because here pulmonary edema is not due to cardiogenic cause, and here there will be decreased compliance and there will be VQ mismatch, because due to hyaline membrane formation, there will be decrease in the surface area for oxygen or gas exchange, so there will be VQ mismatch, and due to collapsing of the alveoli, there will be decreased compliance. And here we will have the hypoxic vasoconstriction due to filling of the alveoli or collapsing of the alveoli. There will be constriction of the surrounding capillary. If this occurs generalized, there will be generalized hypoxic vasoconstriction. This increases the pulmonary vascular resistance and hence leads to pulmonary hypertension. And the main important point to remember is here there will be loss of surfactant that leads to alveolar collapse. Now let's see the causes for ARDS. Causes include sepsis, because during sepsis there will be release of cytokines, and during aspiration pneumonia and trauma and pancreatitis. These are the causes for ARDS. And diagnosis include, here for diagnosis of ARDS, there should be abnormal chest x-rays, especially bilaterally there should be lung opacities, diffuse lung opacities, and there will be due to diffuse alveolar damage there will be bilateral lung opacities on chest x-ray. And the respiratory failure should occur within 1 week of alveolar insult. And the other criteria for diagnosis is there should be decreased PaO2 by FiO2, that is partial pressure of oxygen in the artery divided by fraction of inspired oxygen. This is normally about, that is PaO2 by FiO2 in normal person is of about 500, but there should be decreased PaO2 by FiO2 in ARDS. And hypoxemia due to increased intrapulmonary shunting and diffusion abnormalities. Because there is no exchange of the gas, the blood which comes from the pulmonary artery will not get oxygenated, and then this deoxygenated blood passes through the pulmonary veins and reaches the left heart. So this deoxygenated blood will only circulate around the body. So this leads to increased intrapulmonary shunting and diffusion abnormalities. And symptoms of respiratory failure are not due to HF or fluid overload. Here respiratory failure is not due to cardiogenic cause. Here this is the intrinsic cause of the respiratory system. And the consequences of acute respiratory distress syndrome include impaired gas exchange due to formation of hyaline membranes. There will be impaired gas exchange and decreased lung compliance, and pulmonary hypertension because due to hypoxic vasoconstriction there will be generalized hypoxic vasoconstriction, and this increases the pulmonary vascular resistance. This leads to pulmonary hypertension. And the management or treatment includes, and the underlying cause should be treated first, that is sepsis or trauma or any other causes should be treated first. And mechanical ventilation by increasing the PEEP, that is positive, and expiratory pressure should be positive, increased, and decreasing the tidal volume, that is decreasing the tidal volume less than 500 milliliter. As we can see here, this is the histology. We can see the hyaline formation in the air spaces alveoli, and this alveoli has been collapsed. And we can also see the neutrophil and other inflammatory mediators around the alveoli. And on the chest x-ray we find the shifting of the endotracheal tube. This should be normally midline to the vertebral column, but here we can see the shifting to the right side, and we can see the diffuse opacities because of the collapsing of the alveoli, diffuse alveolar damage, and diffuse opacities can be seen. This is due to ARDS.